So there are a number of reasons why patients can have stiff shoulders. This can either usually be due to traumatic reasons or due to elective underlying conditions. In practice, most patients will know if they've had a trauma, they will have had an injury, in which case obviously an accident emergency department will similarly be your first port of call. Conditions which tend to affect shoulders and make them stiffer depend very much on the age of the patient. So patients between the age of 40 to 60 are more likely to develop a frozen shoulder. And this is very topical at the moment because we've had so many lockdowns with the COVID pandemic and people haven't been doing their usual activities. What happens when you have a frozen shoulder is that the shoulder becomes very, very inflamed, stiff, and goes through a series of phases before it gets better. So it tends to freeze initially, but it becomes very, very painful. Then it goes through a frozen phase where it's less painful, but the movement is still restricted. And then it gradually goes to a thawing phase. The way I try and explain it to patients is if you think about it as being like wearing a jacket, normally when it's loose, you can move the limb freely, but in a frozen shoulder, it's like somebody's pinching the jacket, holding it tight, so you just can't move in any direction. And that's kind of the sensation that patients have. And that's something that's very, very common to be treated, often with physiotherapy and injections, and on occasion requires surgical intervention. The other common thing that we see which causes stiff shoulders is arthritis. That tends to be in older patient groups or patients who perhaps had very physical jobs. And that tends to be something that's diagnosed with persistent pain. It doesn't tend to get easier over time. It doesn't tend to thaw out and stretch out as much as the frozen shoulder. And again, at some point, you'll need imaging in the form of radiographs or x-rays to see what's going on underneath it. Yeah, that's an excellent question. One of the topics we teach all of our students is, shoulder pain can be a pain in the neck. And the reason for that is there's an awful lot of overlap between pathology from the neck going to the shoulder and vice versa. The simplest way to explain this to patients is that your shoulder girdle is made up of your shoulder blade, the ball and socket, and also the joint between the collarbone and the shoulder blade. So those three structures together act to move the shoulder girdle to help us put our hands in space to reach the things that we need to reach. What can happen whenever the shoulder is painful in one particular part, you still need to reach the things that you need to reach, but your body compensates, so it then moves in a slightly different way to adapt. And what can happen is that the shoulder, and especially at the back, the muscle called the scapula, can move in an abnormal manner. And a lot of the muscles that move that to avoid loading the other parts of the shoulder actually connect to the back of the neck. And so it's not uncommon for neck pain, and particularly what we call occipital headaches, so headaches at the back of the head, to be driven from shoulder pathology. It's one of those questions that there's a yes and no answer to every patient. So I don't want to be a politician about the answer, but I would generally say that for any shoulder that's stiff and sore, movement is always something sensible to try and do. And there is certainly an element of use it or lose it. So if we don't use our shoulders, or we don't use any joint for that matter, you get into a vicious loop of not doing it, and then the stiffness becomes worse. Cracking a joint depends really on what you mean by cracking the joint. If you are younger, quite often you'll have clicks, but that's not the same, and that can often be a sensation of the shoulder moving in and out. But that tends to be more associated with people who are actually paradoxically slightly unstable rather than stiff. So that's the younger group. The only good thing about getting older is we don't tend to become unstable as we get stiffer. So you've got to look at some folks and get older. And in those groups, I would say that yes, there's no harm in trying to move the shoulder. If you get an occasional click or crack, I wouldn't worry. But if you are known to have underlying arthritis and you hear a very loud crack and you get significant pain, it's probably worth going to see a physician if you've not already, because it may be that you've got underlying arthritic change in the shoulder and you may need to consider having something done. Excellent question. So we know that most shoulder complaints are usually self-limiting, and they will usually settle over the first 4 to 6 weeks on their own, specifically in the absence of any serious trauma. Simple self-help measures are very useful, so anti-inflammatory medications, if you can take them, moving the shoulder, seeing a physiotherapist, and keeping the shoulder warm and supple is very helpful. I would generally say that for most patients, the main driver to seek attention from health services is actually the fact that they tend to be very debilitating at night, and they really affect your sleep. And anybody who's had small children, when they're awake all night, know just how demoralising and upsetting that is, both for the person who can't sleep and the partners who live with them. So if you get to the stage where you've got persistent pain in your shoulder, it hasn't settled down on its own after simple measures such as physiotherapy and analgesics over 4 to 6 weeks, and your sleep is disturbed, I think it's certainly worth going to get an opinion. On occasion, if the pain is very severe and it follows a specific traumatic episode, then clearly go and seek attention sooner than that. As with all conditions, how you treat them depends on the underlying diagnosis. So in broad terms, if the stiff shoulder was due to a frozen shoulder, mainstay of treatment would initially be physiotherapy, injection therapy with a steroid, although there are issues with that at the moment because of the COVID pandemic, and I would strongly suggest that patients are double vaccinated and have at least 28 days since their second dose of the vaccine before they consider steroid therapy at the moment. And in some occasions, you need to do what's called a manipulation under anaesthesia and a capsular release. So that's a surgical procedure to release the scar tissue. That's a treatment for frozen shoulder. Other frozen shoulders that can be treated with arthritis, as we talked about previously, is if it's not settling down with conservative treatments, that means physiotherapy, injection therapies, then there is an option to treat them with shoulder replacements in some situations. And that, again, is a conversation you should have with a specialist who has an interest in it.